It's about 84.
So hi everyone and welcome to tonight's webinar on pressure ulcers. My name's Kirsty Atkinson and I'm one of the tissue viability nurses at Coloplast. I have been with Coloplast 2.5 years, and prior to that I've got a nearly 10-year history of tissue viability nursing in the acute services. I'll hand you over to my colleague Rommel, who's going to be conducting tonight's webinar, and I'll be on the chat answering any of your questions. After the webinar has finished, you will get a copy of the recording alongside the pathway, and you'll also get a certificate to say you've attended. So I'll hand now over to my colleague Rommel, and then we'll get started. Thank you.
Thank you, Kirsty. Can you see my slide, Kirsty, just to verify?
Yes, we can see it.
Just the presentation slide, nothing notes.
Yeah, just the presentation.
Perfect. Hello, everybody. Good evening. I hope you're all well. Now, so my name is Rommel Orik, as Kirsty mentioned earlier. Now, I am a tissue viability nurse by background. I have been a tissue viability nurse for over 20 years, so I'm getting on a bit. I've got the privilege to be working for Coloplast, and my role here in Coloplast is 50% clinical, so I still do clinical practice. So I see patients with complex wounds in primary care for a complex wound care clinic here in Birmingham, and 50% of my role here at Coloplast is delivering education, generation of evidence. So this evening's webinar is about pressure ulcers. Now, if you're expecting something else, you're more than welcome to leave. Now, I can see a hands up. Sorry, Kirsty. Has somebody got any questions before I start? So I just seen a hands up. But if you haven't, you can speak if you like. Jeremy Albiso. Okay, maybe just accidental raising of the hand there, but let's proceed. So if you've got any questions or queries, please use the chat function. So as I said, this evening's webinar is about pressure ulcerations. So we will be talking, hoping that the slides will move. Okay, it's stuck. There you are. So the objectives of this evening session, we'll be talking about the development of pressure ulcerations, understand how the impact of pressure ulcers from a patient perspective and an organizational perspective. We're also looking at a simplified approach in management of patients with pressure ulcerations. And here in Coloplast, we are about simplification of those framework. So we call it the three-step approach by Coloplast with management patients with wounds or pressure ulcerations. And the format of this session will follow that framework of assess, prepare, and treat, that three-step framework. We're also looking at pressure ulcers recommendations in terms of treatment and prevention of ulcerations. And at the end of the session, you will take away a pathway that will be sent to you, as Kirsty said, and a copy of the recording of this webinar. So what is a pressure ulceration? I think it's always good to start with the definition. Now, I'm gonna talk a little bit slow here because this is absolutely important. So if we manage, or if we are managing a patient with pressure ulcers, or if you are seeing patients who are at risk of pressure ulcers, and more often than not, you'll be asked to either categorize or diagnose a certain wound, whether this is a pressure ulcer. Now, a pressure ulcer, per definition, is a localized damage to the skin or underlying soft tissue. Now, it's usually over a bony prominence. So take note, usually, it's usually over a bony prominence. I'm stressing that phrase. Or any part of the body if it is related to medical device. Now, this is as a result of sustained pressure. So take note of that phrase. This is a result of sustained pressure, or in combination with shear, that's twisting of tissue. Outside of that definition, if you don't think that there is sustained pressure and there is no element of shear involved, that particular wound or skin damage is not a pressure ulcerations. Now, I'm stressing this because I always get asked when a wound is presented, oh, Rommel, is this a pressure ulceration or is this something else? But if we go back to the very definition, is it over a bony prominence? Is there a sustained pressure or is there a shear involvement? As I said, if there's none, It's not a pressure ulceration. So you need to be confident that you know what the definition of pressure ulceration is. A pressure ulcer can also be seen, or it presents itself as an intact skin or an open wound. If you haven't seen the pressure ulcerations before, or you're not so familiar with pressure ulcerations, you probably think, well, what is an intact skin? It's an intact skin. Why is it a pressure ulcer? We're going to go through some of the definition, categorization of pressure ulcers. It can be painful. A majority of the time, actually, it can be painful, unless the damage is very deep. When the nerve endings has been damaged, then generally most of the patients will not feel that pressure ulcerations. But from the very beginning, it can be painful. And as I said earlier, synonym to sustained pressure is intense or prolonged pressure. It has to be intense and it has to be prolonged for it to happen. There are several contributory factors of pressure ulcerations, and one of the most common things is impaired mobility and impaired sensation. So as a nurse, when you've got a patient that comes in and you just think, right, I've got an impaired mobility here, and the patient can't really feel part of his foot, for example, if they got diabetic, you know, highly likely this patient is at very high risk of pressure ulcerations. Stuck again. Sorry, guys, my slide is not moving. Let me just. There you are. Now, I mentioned about sustained pressure. Let's look at it. Let's have a look on what happens at the deeper tissue. So normal blood flow for patients with either at risk or no risk of pressure ulcerations appears this way. If we're looking at the circulation, I want you to look at the left side of your screen. So that is a normal blood flow. You can see the arteries there on the red section, oxygenated blood full of nutrients into the capillaries, distributed into the tissues. If we apply sustained pressure or in combination of shear, this is what happens. You can see that compression of the vessels. Once those vessels are compressed, you're limiting the flow of oxygen and nutrients, and that can result into tissue hypoxia. So the lack of circulation and the lack of oxygen into a certain part of the body can lead into tissue hypoxia. That means the potential start of the dying tissue. So thereby, from a pressure ulceration point of view, it's important that we acknowledge this so we can reposition those patients and prevent tissue hypoxia. Because this is what happens at the tissue level. At an organizational level, if we're going to look at what happens or how pressure also impacts the whole NHS, I want you to look at the middle of the screen. So it's costing the NHS about 1.4 million every day from a pressure ulceration management or preventative point of view. Let that sink in, that figure, 1.4 million every day. A significant amount of money is spent towards management of pressure ulcerations. And if you're looking at mortality of these patients and potentially risk to mortality, for elderly population, the mortality is increased fivefold. Now, that is a significant increase in terms of mortality for elderly patients. In hospital, even up to 25% to 32%. Now, if you look at it, the pressure ulcer, or majority or most of the pressure ulcers can be prevented. These are unnecessary risks or elevation of risk for patients' mortality. And currently in the UK, we had about 700,000 patients are affected by pressure ulcerations. And we can do something about it. And as a clinician, what we can do, struggling to move this slide, is simplify the pathway. And part of that simplification is what we are here in Coloplast is trying to achieve. It's the three-step approach by Coloplast. So step one, we talk about assessment, really looking at a holistic assessment of the patient and not just the wound. From a pressure ulcerations point of view, is identifying that real etiology of the wound. So the question of, is this a pressure ulcer? Is it a true pressure ulcer or not? Once we identify that, it's about preparing that wound to heal. So removing the barriers to healing. For example, devitalized tissue. I'm not going to go through it later. And from a treatment perspective, is looking at a simplified approach in management of those pressure ulcers. Pressure ulcer can be complex, and the management of pressure ulcerations can be also complex. It's an MDT approach, but it's important from a wound perspective. If we can simplify that process, the better. Right, let's look at assessment of pressure ulcerations. I mentioned about rates of mortality to patients, but really let's look at how pressure ulcerations can impact our patients. Pressure ulcerations, patient perspective, can lead into disability such as amputation if it affects the lower limb, particularly for patients with diabetes or impaired neurological function. It can extend hospital stay. It can also lead to bone infection, particularly for pressure ulcers that are close to bone. That's bone infection or osteomyelitis. And once the patient's got osteomyelitis, that can be life-threatening equally. It can extend the patient's hospital stay if they develop hospital-acquired pressure ulcerations, and it can force the patient to some form of immobility. I remember a patient that was nursing how many years ago? She underwent a liver transplantation. Following an extended procedure for liver transplantation, she developed a category 4 pressure ulcerations in both buttocks with exposed muscle and exposed bone. Sadly, for this particular patient, she felt that actually her liver transplantation and her hospital stay was okay. But the most worrying part from her, and that really affected her, is her pressure ulcerations. She felt that she'd lost her dignity, that everybody wants to look at her bottom. The bone was exposed, so she had to be sent to X-ray because of the risk of osteomyelitis. She went home with district nurses, pressure relieving equipment, and she felt that that privacy for recovery was really invaded because of these pressure ulcerations. Now, where in fact, right at the very beginning of her hospital stay, she complained to the nurse that her bottom was sore. They saw that it was red and they just applied the cream, and that was it. And that was the end of that intervention. To me, that was unacceptable. And this is how a simple red area on the skin can progress into a big or massive pressure ulcerations that can lead into this form of complications to some of our patients. So thereby, as a nurse, if you're an experienced nurse, or if you're listening now and you're a student nurse or at the beginning of your career, it is very important that we know some of the risk factors when we are identifying patients who are at risk or elevated risk of pressure ulcerations. Let's look at some of the risk factors, intrinsic factors, for example. These are patient-related factors: malnutrition or dehydration, circulatory abnormalities, or the lack of blood flow from a vascular perspective. You already got a lack of blood flow or blood supply, added pressure on top of this, and in combination with shear, can definitely lead into a pressure damage or damage to the skin. Neurological conditions, sensory impairment. The number one reaction, or it's almost like a reflex reaction of the body when pressure also starts to happen, is pain. Now, this evening, if you are sitting down, now the length of the webinar is about an hour, so hopefully I would not overrun. If you will be sitting in one position for over an hour, you will feel some certain aches and pains in the superficial part of your skin, mainly on your buttock if you're sitting down. And what tends to happen is, you probably wouldn't notice this, you will tend to lean to one side, you will cross your legs, because what you're trying to do is relieve that pressure. So it's an instinct reaction of the body. However, if you've got neurological impairment, sensory impairment, you've lost the ability to actually respond to that stimuli, that there is an increase of pressure here and there is hypoxia, thereby lack of preventative measure in terms of repositioning and relieving that pressure, in elevating the risk of pressure ulcerations. Acute illness, level of consciousness. If the patient is not able to verbalize that she's in pain or he is in pain, that can be a risk factor for pressure ulcerations. Extreme of age. Sadly, as we age, we lost that increased functionality of the skin, or that skin turgor that weakens the function of the skin, thereby elevating our risk of pressure ulcerations. And also to the very young, the skin is still pretty much immature, thereby elevating the risk of pressure ulceration. So those are examples of these intrinsic factors inert to the patient. Let's look at some of the extrinsic factor. Extrinsic factors are on your screen now. Reduced mobility or immobility. The second one there is moving handling aids and technique. So if you're not using any moving and handling aids, if you don't know where your moving and handling aids are, it's something for you to investigate after this webinar. Make sure that we're using slide sheets for patients that are not able to reposition or move themselves up and down the bed. Medications or sedations. Be careful with these patients that are on sedatives. Length of surgical procedure, as I said earlier. And if they're using medical devices, for example, oxygen tubing, that elevates the risk of pressure ulcerations or medical device related pressure ulcerations. And talking about medical device related pressure ulcerations, slightly for those group of patients, they fall under or outside of the common risk of common areas where pressure ulcerations develop. And I think from a medical device perspective, the most common thing I see is from patients' nose, side of the ear, from the use of nasal cannula for oxygenation, or CPAP device for respiratory patients, because they have to put these devices quite tight enough or snug enough for them to be able to receive the oxygen therapy, so thereby elevating the risk of pressure damage from the bridge of the nose of these patients, and sometimes from the elasticated band on the side of their ear or their pinna. But really, the most common sites of pressure ulcerations in this illustration, as you can see, if the patient is lying supine, is the occiput, the scapula, you get the elbows there, the sacrum, the buttock, and the heels. But looking at evidence, the three most common parts where pressure ulcerations develop is the buttock, the sacrum, and the heels. And if your patient is with restricted mobility and is able to sit out, patients that are constantly on a sitting position or prolonged sitting in a chair, or that could be a wheelchair, predisposes the patients to highly likely an elevated risk of pressure ulcerations to their buttock and sacrum. Why is that, I hear you ask? If we are in a sitting position, more than 50% of our body weight is exerted towards our buttock and to our sacrum. And that's heavy enough. Prolonged, sustained pressure definitely can increase tissue hypoxia and development of pressure ulcerations. So for your patients that likes to chair sit, most of the time they're like, oh, I'll just stay on the chair. Dinner is coming now. And then I'll just stay in my chair. Visitors are coming. Make sure that they're able to reposition themselves whilst they are on the chair. So they're relieving that pressure, similar to potentially what you're doing now to reduce that risk. Repositioning is important. So those are some of the most common pressure ulcerations, pressure ulcer areas that we need to watch out for. Identifying risk is great, but we need to act on it from a prevention perspective. Okay, prevention is always better than cure. And how to prevent it? From an evidence perspective, from NHS Improvement of Pressure Ulceration Core Curriculum that was published back in 2018 and including 2020, the ASKING framework was developed. So what does ASKING stands for? So it's an acronym for prevention of pressure ulcerations, and it can be used as an acronym for treatment of pressure ulcerations. A stands for assess the risk. S stands for skin assessment. Surface for other S, K for keep moving, I for incontinence, N for nutrition, and G for giving information or getting help if you don't know what to do. In the UK, or nationally, actually, or globally, should I say, Stop the Pressure Week falls on November. And generally, it's in the last Thursday, no, third Thursday of November. And I think for this year, the Stop the Pressure Ulcer campaign will begin on the 20th of November here in the UK. So I think that's something to keep an eye on in terms of conducting or participating in this global appeal for prevention of pressure ulcerations. Right, let's look at risk assessment, or how to look at skin inspection. From the National Pressure Ulcer Advisory Panel, European and Pan-Asian international guidelines, skin inspection should happen within 6 hours of admission or the first visit or clinic appointment within 6 hours. Okay, so you've got that 6 hours leeway in terms of skin inspection. Prioritize those. And that is part of your risk assessment of the patient, making sure that we do a thorough skin inspection. When I say a thorough skin inspection, head to toe, cephalocaudal, and increase the frequency of skin inspection if the patient's condition deteriorated. Ongoing skin assessment depends on the clinical setting that you're working on. I would encourage you to check your local guidelines in terms of how often you do a risk assessment if the patient's condition is stable. But from a skin perspective, making sure that we're inspecting the skin from head to toe, making note or respecting the patient's dignity at the same time. Younger patients that you want to protect their dignity or refuse a skin assessment, absolutely they can. That's the patient's prerogative. But what I'm trying to say is we need to offer the possibility and the opportunity for us to inspect the patient's skin so we can identify their risk of pressure ulcerations. So offer it to them. And if they say no, thank you very much. I'm young enough, I'm fit enough, I'm mobile. I'm happy that my skin is okay. Just document it. Okay. After skin assessment, use a risk calculator tool. The most common risk calculator that we use here in the UK now is the Purpose T. It's quite a nice tool. Less laborious versus the Waterloo or the Braden scale. Initially, it will ask you to risk assess your patient from a mobility and skin, and that also includes your clinical judgment as a clinician, whether this patient is at risk or not. And if you deem that this patient is at no risk at all, and that would be it. That is the procedure done from a risk assessment point of view using a Purpose T. So I think that's the beauty of Purpose T. I like that tool. If you're still using a Waterloo, at some point there will be that transition, because what the aspiration is within the UK is everybody should be doing a Purpose T. But not to worry if you're still doing other risk assessment tool. It's up to your organization or when that switch needs to happen. But as long as you've got a form of risk assessment tool, that would be great, because this risk assessment tool will direct you in terms of what the management strategies would look like or care planning would look like from a contents perspective, equipment, etc. I think my next slide is about, yeah, perfectly, pressure relieving equipment. So depending on your risk calculator or your clinical judgment, if the patient is at risk or elevated risk of pressure damage, highly likely it will probably ask you to consider pressure relieving or pressure reducing equipment. What's the difference between the two? Pressure relieving is powered by electricity. You have to plug in, alternating system. Pressure reducing, generally non-powered, okay, static equipment. So these devices are around to help you manage a patient either with a pressure ulcers or at risk of pressure ulcerations. They are not, I stress this, they are not a replacement of repositioning. Okay, this is to aid you in terms of relieving that pressure of a specific patient. But you need to engage with the patient in terms of this provision of equipment. Some patients don't like alternating equipment. It makes them feel dizzy, it makes them feel seasick. Okay? And depends on the space and where the patient lives as well. But just be mindful. So patient engagement, consult the patient around this, and also availability of equipment. There's only so much equipment that are around. So it's making sure that we're utilizing this equipment to those patients that who really need it. Sometimes what I've noticed in clinical practice is some clinicians will just get them this equipment just in case. We do not have infinite amount of resources in the NHS. So it's making sure that we are recommending equipment when they are suitable and when they are appropriate. Do your risk assessment. Right. So as I said, it's not a replacement of repositioning. So if your patient is a pressure relieving equipment and you need to reposition them from, for example, for this particular patient in front of you, from a supine lying flat, if you want to sit this patient up, use your knee brace or brace that knee. As you can see here, it's going down. Okay, bend the knee, lock down, sit the patient up. That prevents that shearing forces across the buttock of the patient. If you don't break that knee, what happens is the skeleton will slide down. So if you imagine the skeleton of this patient will slide down and the flesh will stay as is because of gravity, that is what I call a shear forces. And that can increase the risk of twisting or torsion of the muscle leading to tissue hypoxia or potentially deeper tissue damage, leading into pressure ulcerations. Okay, I'm gonna do the illustrations again from a lying flat position. Oops, there we are, lying flat, knee break, and sit the patient up. So there's no movement. There you are. There's no movement from the skeleton. So you're preventing the shear forces. That's the correct way of positioning a patient from a supine to a semi-recumbent position. 30-degree tilt is still very much appropriate when positioning the patient from side to side. Rock and roll on a chair. So I say rock and roll. So just basically just rolling from the chair side to side. I'm doing this while I'm sitting there. I don't know whether you can see it or you've got your camera on, but basically just sitting on one side to the other. Okay, relieving that pressure. Repositioning is still the key or one of the best strategies you can do from a patient from a pressure ulcer prevention point of view. Moisture associated skin damage generally sometimes can be misclassified as a pressure ulcerations because of the location of the damage. It's worth highlighting that moisture associated skin damage, or MASD, is part of the risk that can elevate for patients who develop a pressure ulcerations because already of the weakening of the skin. And if it happens into the buttock or the sacral area of the patients because of urinary and fecal incontinence, you already got a weakened skin there. So that can elevate the patient's risk of pressure ulcerations. But we are not to confuse this with pressure ulcerations because the cause of moisture associated skin damage, by the definition itself, is caused by moisture. To define different types of moisture associated skin damage. On this occasion, from an incontinence-associated skin damage relating to urinary or fecal continence, what you can see in the image there is the patient's buttock, and also close to the natal cleft, where mostly moisture lesions happens, and it presents itself as superficial, irregular in shape, on a kissing ulcer. There should be no necrosis or the absence of slough at the wound. Unlike pressure ulcerations, pressure ulcers generally defined as a defined ulcer to a bony prominence. So this one is quite spread out, as you can see in the image there. It's quite superficial in nature. So if you're looking at a wound, patients with double incontinent and it's superficial, irregular, kissing or butterfly lesions in presentation, highly likely that is a moisture-associated skin damage or incontinence-associated skin dermatitis. The management strategy here is different. Continence aid, okay, appropriate pad, skin cleansing, skin protection, rather than pressure relieving equipment and repositioning. Of course, you will still reposition this patient if they're at elevated risk of pressure ulcerations as well. Nutrition, optimize our patients, okay? As part of your risk assessment, making sure that our patients are eating a balanced diet, easily said than done. But from a pressure ulcer management perspective, patients with pressure ulcer should have an intake of 30 to 35 kilocalories per kilogram per day. Okay, that's quite a lot of calories to ingest extra on top of what normally they're eating. So irregardless where you're from a wound care management perspective, whether it's a pressure ulcer or not, a wound, if we look at it this way, is a damage to the skin that needs that extra fuel to heal. And that fuel will come from the food that we eat. So if we've got pressure, we got patients that has got a pressure ulcer, making sure that we increase protein intake and increase carbohydrate intake. I always say to my patients, it's not a good time to be dieting if you've got a significant damage to your skin, because we need that extra calorie and we need that extra protein to heal that wound. Otherwise, this wound will continue to be static or deteriorate if we're not lucky enough. So that's from a nutritional perspective. Having completed all those risk assessment, implemented the asking framework from a prevention perspective, if you happen to have a patient and still develop a pressure ulcerations, it's important now that we assess that wound. From a wound assessment perspective, here at Coloplast, we have the triangle wound assessment. Again, simplifying that thought process when we're looking at the wound. So we'll start with the wound bed, the wound edge, and the peri-wound skin in terms of looking at the clinical presentation. Okay. You will have your own framework, perhaps. If you're not using the triangle wood assessment, you probably will have the time framework, the timers. But here, simplified process, the triangle wound assessment. Again, I'll repeat it. When we're looking at the wound or a pressure ulcer, look at the wound bed. What can you see? Then look at the edge and then look at the peri-wound skin. So it's quite a good process from center to edge to the surrounding skin. Okay, good process to remember, good flow. If you are presented with the pressure ulcerations, you are required to categorize the pressure ulcerations and to classify this. And this presentation is following the European Pressure Ulcer Advisory Panel recommendation that was published back in 2019. Okay, so these are the definitions. So what is a category 1 pressure ulceration? A category 1 pressure ulcer is an intact skin with non-blanchable erythema. Okay, so this is an intact skin, I mentioned earlier, with non-blanching erythema. That means persistently red. Okay. Now, I've been talking for almost about 30 minutes here now, so I'm not sure whether you're using the chat function, but I'm going to ask you a question. Okay. So how long do you press a patient's skin to assess for blanching or non-blanchable erythema? So if you spot a reddened area, if I'm asking you to assess a non-blanching or blanching erythema, the way to assess that is to apply pressure to the reddened area using a finger. Now, I'm asking you, how long do you press or apply pressure to the reddened area before you let go to be able to assess a non-blanching or blanching erythema? I'd like you to
We've got
use
a
it.
couple of sorry,
Go on.
Ronald. We've got a couple of answers already in the chat. So we've got 3 seconds, 10 seconds, 2 seconds, 5 seconds, 10 to 15, another 5, another 5, another 2, another
Okay.
5.
Oh,
5
2 is
and
a bit
2 seconds seems to be the winner. 3, 5, yeah.
Okay, along those lines. 2 is very quick. 2 seconds is very quick. It's about 3 seconds. Okay, similar to capillary refill, really. So look at the reddened area, press the reddened area after about 3 seconds, let go. If the area blanch, that means it turns white and then red again. That's a blanching erythema. So that means that the skin is still intact. The damage hasn't happened yet, but that is a warning sign. But it doesn't mean that you can just say, yes, hallelujah, I don't need to reposition this patient. That is just a beginning sign, that warning, alert, alert, okay? However, if you press and hold for about 3 seconds, you let go and it's still persistently red, non-blanching erythema, that is a category 1 pressure ulceration. And this is important. We need to get this right because this is the very beginning signs, or this is the very beginning of the damage of pressure ulcerations. So that's why an intact skin persistently red is categorized as a category 1 pressure ulcerations. Well and good for whites or fair skin. It is recognized for darkly pigmented skin. It's difficult to establish a category 1 pressure ulcerations. So what do we need to do? From an assessment perspective, we need to be vigilant with darkly pigmented skin. We need to looking at temperature changes from the area. Have a feel, okay? Use palpation, feel for edema, change in consistency. We'll be looking at induration or hardness of the tissue that's potentially affected. This will be going to be over a bony prominence. So look for those bony prominence, have a feel. Patients will say, my bottom is sore, my sacrum is sore, my heels are sore. Have a feel. Is it cold? Is it edematous? Mainly induration is what I've noticed in clinical practice that tells you. Pain and induration generally for darkly pigmented skin. So be vigilant. Okay. So that is a category 1 pressure ulcer. I think simple enough. Now, well done to all of you who said 3 and a bit longer, absolutely fine, acceptable. As long as we're not talking about 20 minutes, that's too long. That's prolonged, sustained pressure. Okay, so it's only seconds, 3 seconds. Right, category 2. A category 2 pressure ulceration is a partial thickness skin loss. Superficial. The damage is at epidermis and dermis layer. Okay, generally it appears. If we're looking at presentation, it may appear like an abrasion. Okay? If you've got an abrasion, it's very much superficial in terms of damage. An intact blister, serum filled, clear blister is categorized as a category 2 pressure ulceration. D roof that blister, again, category 2 pressure ulceration, as long as it's superficial. No adipose fat is visible, no deeper tissue should be visible. No granulation tissue, no slough, and no eschar. So this should be a nice, clean, red, superficial damage, category 2. Do the asking framework from a preventative perspective, highly likely there's a good chance that this patient will recover, or this category 2 pressure ulcers will heal fairly quickly, depending on the medical condition of the patient or the comorbidities of said patient. Let's look at category 3 pressure ulcer. Now, category 3, we're now going into deeper tissue. It's a full thickness skin loss, full thickness tissue loss, where adipose fat may be visible. Okay, so you can see a fatty tissue, but bone, tendon, or muscle are not exposed. If you can see those structures, that particular one is a category 4. So here, at epidermal layer down to adipose tissue, without visibility of the muscle or bone, granulation tissue might be present. Okay? You may also see the rolling of the skin edge. Slough and eschar could be present, undermining or tunneling. At this particular point, this particular wound will have some depth to it. Okay, so you will see from a wound assessment perspective that there's some depth to this particular wound. But again, that depends on the location of the wound. Because if we're talking about a patient's heel, or if it's a medical device related pressure ulcers from the bridge of the nose, from a superficial dermal layer, you straight down to cartilage there. So depending on the location of the wound, highly likely a category 3 would present itself as a cavity, but sometimes it can be superficial depending on where it is. Category 4 pressure ulcerations. Now I would class this as severe pressure ulcerations really, because we're now down to muscle or bone layer or palpable bone. So significant damage. So there's a significant sustained prolonged pressure here to a patient that's already depleted. Thereby you've got this deep wound extending right up the fascia, muscle, tendon, ligaments, cartilage, or bone. It's a deep wound. Potentially, again, the presence of slough and eschar might be visible. Depth can vary depending, again, on anatomical locations. High risk of potential osteomyelitis because of bone involvement. And that is a category 4 pressure ulcerations. Now, categorization of pressure ulcerations requires you to be able to identify the layers of the skin. So it's important we know the layering of the skin from epidermis, dermis, adipose tissue, muscle, fascia, bone, or ligaments and tendon. If you're not familiar with the layering of the skin and the tissue and the underlying tissue, it's something that I want you to be familiarized of, because when you are categorizing a pressure ulcerations, you are relying on the knowledge of the layers of tissue that are involved from a structure perspective. So that is category 1, 2, 3, and 4. If you're following the National Wound Care Strategy Program, that's probably the category that you'll be very much familiar. However, not everybody in the UK is following that recommendation. And as I said from my presentation earlier, this presentation follows the European Pressure Ulcer Advisory Panel, and some other trusts or institutions are still using the next category, which is the unstageable or pressure ulcer depth unknown. What this means is if pressure ulcer is covered with a significant amount of devitalized tissue, either a slough or an eschar, and the clinician is not confident enough that they can see or they can assess the level of depth of damage to the tissue, they will class this particular wound as unstageable pressure ulcerations. Okay? And highly likely, once we remove this devitalized tissue, this particular wound will either reveal itself as a category 3 or a category 4. controversial if it's a category 2, because that's not within the definition of it. But really, from an unstageable pressure ulcerations covered with thick devitalized tissue, highly likely it can only be a category 3 or a category 4 once we prepare that wound to healing. And we also have the last category, which is the deep tissue injury. And this is defined as a purple or maroon localized area of discolored intact skin, non-intact or blood-filled blister. Okay, so blood-filled blister relating to pressure ulcerations, nothing else, can be classed as a deep tissue injury if we are following the European and the EPUAP classification. Okay, if you're following the National Wound Care Strategy Program, this would be a vulnerable skin as part of your risk assessment. I'm gonna stop there in terms of categorization, and that is the whole category of pressure ulcerations. Once you categorize the pressure ulcerations, you know the risk from your purposely or Waterloo. You're now in the process of formulation of management strategy. We need to make sure that we engage with the patient. Okay, discuss with the patient the management strategies that you're going to do from a nutritional perspective. That could be relating to moisture, or in combination with moisture if there's a moisture challenge from a skin perspective. Increase nutritional intake, pressure relieving equipment, frequency of repositioning. We need to make sure that the patient is on board, or the patient's carers are on board, or whether this is realistic. Okay, we need to set some realistic goals for prevention of pressure ulcerations, or the management of pressure ulcerations. Okay, and we are discharging this patient to a different institution. We need to make sure that that handover is clear. Okay, when I say the handover is clear, is we need to communicate from the receiving end what type of equipment potentially this patient will require, the level of care the patient needs. Okay, so we're making sure that we're providing the consistency of care from a care plan perspective. We're now going into prepare. So from a pressure ulcerations point of view, I mentioned earlier about unstageable or pressure ulcers covered with devitalized tissue and slough. And those are some of the challenges that we see in clinical practice. So a pressure ulcer on the left side of your screen, as you can see, is covered with devitalized tissue. So those are a cause of potential bacterial buildup. Okay? Bacteria likes to live in a wound where it's full of devitalized tissue. They feed on them. So you can see the inflammation of the surrounding tissue on that particular wound there. Okay. On the right side of the screen, you can see hyperkeratosis. Now, this is common if the pressure ulceration, for leg ulceration is very common, we know that. But from a pressure ulcerations point of view, if the pressure ulcer is located, for example, the ankle or on the patient's heels, on the patient's foot, you will see some form of hyperkeratosis. And these are some of the challenges that we face, not just from categorization perspective, but also treating this patient's pressure ulcerations, looking at wound healing or rapid wound healing as a key objective. If the patient's wound is covered with slough and non-viable tissue, it limits our ability to be able to assess this wound correctly. If we can't assess the wound correctly or categorize the pressure ulcer correctly, it may lead into an incorrect treatment pathway for a specific patient. So thereby it's important to consider debridement of this devitalized tissue so we can visualize it properly, reduce the risk of wound infection, and ultimately promote the formation of granulation tissue. The longer we leave a devitalized tissue over a patient's wound or a pressure ulcer, for example, can lead into what I call chronicity. We're now going into what we call transition of an acute wound or a start of a wound injury going towards chronicity. And chronicity means potentially any form of bacteria can lead into the formation of biofilm. Hard to heal wounds, normally or commonly pressure ulceration sits within this category purely because of the hard to heal nature healing of this particular group of wounds are highly likely at risk of biofilm formation. That's something that we need to watch out for. And some of the signs and symptoms of biofilm or presence of biofilm in the wound bed is delayed healing, increase in wound exudate and slough. Now those slough that comes back very rapidly and comes away very quickly, some signs and symptoms of biofilm formation there. It can increase inflammatory response. That low levels of erythema at the wound edge, that sometimes accompanied by malodor. Those are some signs and symptoms that we need to be watch out for if we're thinking there could be a biofilm presence here. I'm saying this is an important strategy for you guys to be aware from a pressure ulcerations point of view, or in general, a hard to heal management wound perspective, because the management of this type of wounds will include what I call a multimodal approach. So not just a simple application of dressing, but it needs some element of thorough wound preparation. And what I mean by that is mechanical or a good debridement from a wound perspective itself and the peri-wound skin. Use of a dressing that will actually sequestrate or trap the bacteria within the body of the dressing. And if you're suspecting a wound infection, use an antimicrobial dressing that will actually address microbial level of the wound bed. And we need to do this regularly and repeatedly. Multimodal, regularly and repeatedly. Okay. And hopefully, if you're seeing a pressure ulcer with potential biofilm, you're unable to establish the wound depth of the wound bed. If we do this regularly, then we'll be able to visualize that wound bed, promote granulation tissue formation, and hopefully get this patient into some form of healing trajectory. What essentially we're doing there is removing the barriers to healing. Okay, so this is now not just wound management, this is about wound healing. Easily said than done, but it's good for you to be aware of, because these are important steps that we need to consider when we're managing a wound or a complicated pressure ulcerations or a hard to heal pressure ulcers. And if we're looking at mechanical debridement and the benefit of debridement to your wounds, this is a study done by Wilcox that was in 2013, looking at over 100,000 of diabetic foot ulcerations in terms of wounds. And they discovered, which is very much we see in clinical practice, or I see in my own clinical practice, that regular debridement equals speed in terms of wound healing. So from this particular study point of view, diabetic foot ulcerations, debridement once a week versus twice a week, every 2 weeks of debridement, healing time for DFU with once weekly debridement is 21 days, whilst diabetic foot ulcerations receiving less debridement, that's every 2 weeks, heals within 76 days. So if we do regular debridement, regular mechanical debridement and wound cleansing, we speed up the wound healing by 3 to 4 times versus non-debridement or less debridement. Okay? Let's just support the argument or the clinical practice in terms of promotion of regular wound debridement. There are other not hundreds, there are several types of debridement, autolytic debridement. But what I would really like to stress is in the middle part of this slide, the mechanical debridement. Outside of the nurse specialists, advanced wound specialists, or tissue viability nurses, or vascular nurses, where they can do surgical or sharp debridement, the generalists should be able, or I would encourage you to be doing mechanical debridement. Okay, mechanical debridement is basically using a tool and cleansing the wound and the peri-wound skin with some form of solution to remove the devitalized tissue with some element of force. Okay. Generally, the barrier to debridement is some of the generalists will say, well, I can't do debridement because I haven't got a specialist skill. Mechanical debridement sits within the middle here in terms of this pathway that doesn't not require extended competencies or training. Anybody can do mechanical debridement. I am working with a healthcare support worker in my clinic, and I've shown her how to do mechanical debridement using an all prep pad. That's something that we use in clinic here in my clinic, and she's doing mechanical debridement. I ask my patients to do mechanical debridement themselves when I am sending them to the supported self-management to participate in their own wound care. So really, from your perspective, there's no reason why you should not be able to do some element of mechanical debridement. And I think a lesson from tonight really is looking at how you can improve your clinical practice and consider mechanical debridement, because this is an important or a key step in terms of the framework in getting the patient to this healing trajectory. Okay, from a best practice statement point of view in management of cavity wounds, and not just cavity wounds, okay, also superficial wounds that are covered with devitalized tissue. Here at Coloplast, we define cavities deeper than over 2 centimeters in terms of depth. Okay, but there's no standard definition of what a cavity would look like. Okay, Um, so if you were seeing a cavity wound, and if you're seeing a superficial wound equally, and you think, right, it's covered with devitalized tissue, I need to categorize it, I need to prepare this wound to healing, use some mechanical debridement tool. What you can see in the image there is an old prep pad. So that's a mechanical debridement tool that anybody can use, patients, non-qualified practitioners, and equally, if you're a specialist, it can supplement your skill. After you've done your sharps debridement or curettage, it's good to finish it off with a mechanical debridement pad. We need to be thorough, particularly if we're looking at biofilm, anti-biofilm management, because we can't see bacteria. So if we are thorough in how we prepare the wounds, we will only be rewarded by a rapid wound healing or achieving that good wound healing trajectory. How often should we be debriding these wounds? Based on your clinical judgment, really. So I would say regularly and repeatedly. Every opportunity you may have to a specific patient. I always say to my patient, I want to maximize your visit into my clinic. So thereby, I maximize your visit to your patients. Do thorough, regular, repeated debridement. Encourage your patient to participate in the debridement so you can do it more often. We know from the evidence that I've shared earlier that regular debridement can lead into faster wound healing 3 to 4 times. And those are in diabetic ulcerations. But we need to be cautious when we're doing mechanical debridement. Okay, if the wound is on the lower limb or the patient is at a higher risk of bleeding, we need to approach this with caution. Okay, or if the patient has got poor ability to heal their wound because they have their underlying medical conditions and they're taking cytotoxic medications or they're immunosuppressed, just be vigilant for this group of patients. But really, key things to remember: lower limb, be vigilant. Patients taking high dose of anticoagulant therapy, inability to heal a wound because of the medical condition, or pain sometimes can be a barrier when we're doing wound bed preparation. That's a different session on how to combat those challenges, but just something to be mindful of. Now we've treated that wound. I'm slightly conscious of time. I think we're now close to the end of the session. We're now going to treat the wound. Treatment, we need to be specific, okay, in terms of our treatment objectives. We need to break it down into segments. Don't document that heal the wound in 2 weeks for hard to heal wounds of pressure ulcer. That's potentially quite impossible. So break it down, prevent maceration, okay, promote granulation tissue formation, or reduce slack of the wound bed. So break it down into more achievable objectives is what I'm saying if we're going to be identifying treatment objectives from a patient perspective. There are different types of dressing categories that are out there. Okay, here at Coloplast, we really want to champion simplification. So the simple that dressing in terms of dressing application, less combinations, the better. Because tendency is what I see in general practice is most of the generalists or any other practitioners really, the more combinations you give them, the more confused they are. Okay? I've seen different types of combinations and layers of dressings, and sometimes I stood there just thinking, well, what's going on here? I've got foams, I've got alginates, I've got film dressings, and I've got hydrocolloid. It's just a sandwich of everything. Okay, but just to be mindful that there's different categories of dressings. But the purpose of this presentation, we need to consider a dressing that can manage most of the symptoms from a wound perspective. Manage wound exudate, not just ability to manage wound exudate, but for a cavity wound that's got the ability to contour. I'm not talking about micro contouring here. I'm talking about macro contouring. Okay, so what you can see in the image there on your screen is a cavity wound. There is a defect on the patient's skin. It's about approximately more 2 centimeter, probably less really. Using a biotin silicone dressing because of the ability of the dressing to 3D fit. With this type of wound, you don't need to pack that cavity wound there. You can apply the dressing correctly. So from that perspective, that's simplifying that process, less combination. Because what the dressing will do is mold onto the contour of the wound bed. And it will manage wound exudate as a management of the symptoms, retain that wound exudate into the body of the dressing, even under pressure. So from a pressure ulceration perspective, this is very important because if the patient would lie on top of that dressing, the fluid or the wound exudate will not squelch out of the dressing because the biotin foam dressing got the ability to retain that moisture, not just moisture, but also bacteria within the body of that dressing. So it can withstand some form of pressure without allowing the wound exudate to leak out. Again, that's simplifying that process. A dressing that can manage a significant amount of symptoms from a wound perspective. Just an example. So what does it mean in clinical practice? So this is a case study of a patient called Jamie. He's a 39-year-old patient who's got a pressure ulcer for over 15 years. So as you can see on day one of the assessment of his pressure ulcer, he's very independent. He's a young chap who's 39, wheelchair bound. There's a significant amount of macerated skin at the wound bed. So the wound is located at the ischial tuberosity. The patient suffers with spinal bifida. On assessment, they felt that they need to remove some of the macerated tissue at the wound bed to reduce inflammation and hopefully reduce level of exudate. So by using all prep pad, they managed to remove most of the macerated tissue at the wound bed. As you can see on day 16, you can now see what's going on from the exact depth of the wound, really without the macerated tissue. After day 16 of using all prep pad, and they use biotin alginate AG to manage the cavity wound, to reduce the bacterial burden. They managed to reduce the wound exudate, and the patient felt that is less leakage and there's less pain, and eventually the patient healed. So again, simplification of the process. Now, this is just one case study of a patient with pressure ulcerations using the assess, prepare, treat framework. Now, of course, we're using, I'm just sharing to you what the products here that are used for this particular patient. But again, what is important, consider the asking framework as part of this. Repositioning is key. Check the equipment of the patient that is still suitable. Luckily, this patient is able to reposition and he's got appropriate equipment because it's a long-standing condition. So it's just part of those treatment strategies that we need to consider when we're managing patients with pressure ulcerations. What that means in clinical practice, here at Coloplast, we've been gathering evidence to support that simplified framework of this three-step approach. So this is a 60-patient evaluation that we published last year. Now, based on this study, the 60-patient cohort had an average wound duration of 55 weeks. That's over a year. Now, from a clinical perspective, that is a significant amount of time that this patient has got these long-standing wounds. So this patient was enrolled into the three-step approach framework by Coloplast using the assess, prepare, treat, and then using all prep pad for wound bed preparation and the biotin silicone range or the biotin range to treat their wounds. Do it regularly and repeatedly. These patients, who's got an average wound duration of over a year, managed to achieve wound healing by 6.6 weeks. These 60 patients, 10 of them came from my clinic here in Birmingham, and 50 of them came from Kirsty's clinic in the Northeast. We had managed to achieve 85% of patients healed. With all of these patients did not receive any antibiotics during the treatment pathway with us. And that just gives you the confidence that from an evidence perspective, this simplified framework do work in clinical practice. And I can tell you that because I do it regularly in my own clinical practice. Again, remember, assess the risk, prepare the wound, use a simplified approach in management and that wound symptoms. Use a dressing that can manage most of the symptoms, avoid the confusion, and promote the consistency of care to your patients. I'm conscious of time. I'm just going to move in now to these are the pathway that you will receive. And this is a simplified pathway with product selection guide from Coloplast. It's a good guide. It's a good simplified guide that you can use in management of patients with pressure ulcerations. Okay. If you have any queries, particularly on the product or about the assess, prepare, treat framework, scan the QR code. I'm just going to give it a couple of seconds now. So you have the opportunity to scan the QR code, complete your details, and some of my colleagues at head office will be in touch with you to help you with any queries following this evening's webinar. My mouth is dry and I've been talking for about an hour, and hopefully that helps. And it's a very quick webinar on pressure ulcerations. We do study event of a full day around management and treatment of pressure ulcerations. So really, this is just an overview on how we manage pressure ulcerations or prevent pressure ulcerations using a simplified approach, including some of the asking framework that's been recommended from the National Wound Care Strategy Program and the European Pressure Ulcer Advisory Panel. So thank you very much for listening. I'm going to stop sharing now and let's see if there's any questions from the audience.
No questions in the chat, Rommel, but there
Okay.
was quite a lot of people shocked by how much pressure ulcer costs a day and
Okay.
how many extra calories are needed to help support wound healing.
Okay. Good. Well,
But no
I can see
questions.
yes, I can see a lot of thank you. So you're very welcome, guys. So, yep, I finished bang on time at 8 o'clock. So enjoy the rest of your evening, and I hope to see you in some of our future webinars. All right, take care, guys. Bye.